Welcome, everyone. So glad to have you join us this afternoon for a discussion on initiating medications for opiate use disorder, presented by our own Dr. Bhatt. For those of you who may not be familiar, Dr. Bhatt is a 2001 graduate of the College of New Jersey, then went on to do his medical school at the University of Medicine and Dentistry of New Jersey, Robert Wood Johnson. And then he completed his residency in general psychiatry at the Robert Wood Johnson Medical School. Dr. Bhatt joined us here at UNM to complete an additional 1 year of training in addiction psychiatry, finishing in 2010 and staying on since then. He currently is the chief of addiction psychiatry here at UNM. He provides much of his clinical care at ASAP. He's also very engaged in clinical and implementation research and is impassioned by trying to establish systems that make access to evidence-informed treatments more available to more people. I have had the privilege of working with Dr. Bhatt since I started here in 2014. Just find him an amazing psychiatrist, but an even more remarkable human being, and am looking forward to hearing what he has to share with us today. So, Dr. Bhatt, it's all yours.
Thank you, Dr. Waldorf, for that generous introduction. And I'll go right into this. And I said I had no disclosures, but I guess I do have a disclosure, although not a financial one. Dr. Waldorf and I were talking right before this, before everyone came on, about like consistency of messaging, right? And I was telling Dr. Waldorf that I'm always impressed by her consistency of messaging. And I guess if there was one messaging that I'm very consistent about, is that we really need to be not delaying initiating medications for opioid use disorders for our patients in all settings, whether it's in PES, whether it's in PUC, whether it's in outpatient clinics, whether it's in the community. And I think that's been like as consistent a message that I've been on for my whole, I guess, career as faculty member here at UNM. And I think that's partly why I opted for this presentation today, because how we start medications for opioid use disorder has really shifted. And I think it's really made it exciting and increasingly feasible that we are able to get patients on our life-saving medications as soon as possible. So that's really why I picked this topic. So we're going to talk a little bit about the history. Like, I want to talk about the evolution, because hopefully that would be interesting for people listening, trainees, faculty, and others alike. How did we start our quote-unquote traditional methods of starting medications, both methadone and buprenorphine? How have they shifted, right? And what the role that kind of fentanyl has played in bringing about that fairly rapid shift. And I think it's more exciting than ever now in terms of how we start our patients with opioid use disorders on these medications. So I'll start with our traditional initiation methods, how and why, right? So that's what I'll start with to hopefully trace the evolution a little bit. So I'll start with methadone, right? One of our 3 FDA-approved medications for opioid use disorder has really been around since the 1970s. Wonderful medication. But this is how we initially started methadone. So per federal law, this is codified in the federal law, that the first dose of methadone that I can give someone when they come to ASAP, if they're not already in treatment, until very recently used to be no more than 30 milligrams. So if I was here 6 months ago here at ASAP, a patient came in wanting to start methadone, I evaluate them, I make sure they have opioid use disorder, and the first dose can be no greater than 30 milligrams. And on day 1, I could redose them to go up to a maximum of no more than 40 milligrams. After that, and this is not part of federal law, but this really has been for a long time the standard of care here in Albuquerque and around the country, small increases of 5 to 10 milligrams every couple of days, basically, until people get to about 60 milligrams of methadone. And really over that time, it was recommended that we don't go up more than 20 to 30 milligrams in a week, right? If you're going up more than 20 to 30 milligrams in a week, we were too aggressive and we could potentially kill this patient. So don't do it. And once they get to 60, the prevailing wisdom historically had been to then go up by 5 to 10 milligrams about every 5 days until symptoms are controlled, right? So that was the traditional initiation of methadone used for over 5 decades until very recently. So why? So on the left, I have the rationale, and on the right, some challenges that I see to that approach. So the rationale was that in some early studies, really using people without physiologic dependence on opioid, it was found that a dose of 30 milligrams will not be fatal to a healthy adult with no tolerance. So you could give it to me right now, 30 milligrams of methadone. I might get a little bit sleepy, a little bit sedated, but I'll be okay. I will survive, thankfully. And a dose of 40 milligrams is the very least needed in some early studies to control even the worst of withdrawal. So that was the rationale. And the reason for not going up too quickly historically has always been that methadone's average half-life is about 24 hours, although there is a lot of human-to-human variability. On average, we say about 24 hours, so steady state is achieved at about 5 days. So you really want to wait to go up, right? So rational approach, I think, but there are many challenges. One is that our patients have tolerance. Our patients have very high tolerance very often, right? They're not opioid naive. And we know that most patients need a target dose of at least 80 and 120 milligrams. In fact, now in the era of illicit fentanyl and other high potency synthetic opioids, that number has gone up even more. But even until very recently, the target dose for most people was about 80 to 120 milligrams, right? So you can see that if we're going up this slowly, it's going to take weeks for people to get to a therapeutic dose of methadone. And I think that's a big challenge, right? And a big negative. And in fact, studies have shown that higher doses of methadone, so methadone doses of 60 to 80 milligrams and above, show superior outcomes compared to low doses in terms of abstinence, in terms of treatment retention, in terms of psychosocial rehabilitation. And higher doses of methadone, 60 milligrams and above, actually are associated with a reduced risk of fatal heroin overdose during treatment, right? And I love this quote. It's by Vincent Dole, who's considered one of the founders of methadone maintenance treatment. And he said this in 1988. And again, since I'm giving a historical perspective, I threw this quote in. As with antibiotics, the prudent policy is to give enough medication to ensure success. So don't be stingy with methadone. But what we're essentially doing is titrating so slowly with an eye on safety that there is a higher risk of treatment dropout. People may leave treatment because they're still withdrawing. And because they're withdrawing, they may continue using other opioids. And that's risky, right? Because now people are using a little bit of methadone and a little bit of other opioids, whatever they may be taking. And in fact, we see this in some studies. So this is a study from 2002. A lot of the methadone studies are older, admittedly, because we just don't do many clinical trials with methadone in 2025. But what this study showed is that with methadone, what you see is that in the first 2 weeks of treatment, when someone initiates methadone, the overdose mortality rate actually rose in the first 2 weeks, right? By about threefold. And then it dropped. And then it became life protective with continued treatment. But in the first 2 weeks, we see this bump in mortality. And at least there are many reasons why this could be happening, but one proposed idea, and to me this makes sense, is this idea that people are on a subtherapeutic methadone dose. So they might continue using other opioids, and now we're getting a dangerous combination effect, right? So what was the traditional way to start buprenorphine? That's a little bit about methadone. Let's do the same for buprenorphine, right? So I still remember this. I've been working with buprenorphine since 2003, since I was in medical school. It was brand new. I knew I wanted to do addiction psychiatry. And I was fortunate enough to get involved in some research projects. And this is how we did it, right? The official guideline was that buprenorphine must be started in the physician's office. And at that time, it was physician alone, not nurse practitioners, not physician assistants. It had to be an MD or a DO. It had to be started under direct observation in the office. So the patient would have to come into the office in withdrawals. Imagine how tough it would be. We were telling patients, if you're using heroin or oxycodone, wait at least 12 hours before you come in. So now we're having patients feel miserable, come into the office at a pre-assigned time, and then we start them on treatment, right? So that's the one challenge that, I can certainly appreciate, and maybe many of you can as well. How realistic is it for our patients to do this, right? Be able to do this. Then we would start with up to a 4 milligram dose, sometimes 2 milligrams. So we started at 2 milligram dose, sometimes a 4 milligram dose, but not anything more than that, because that might be too risky, right? And on day one, we didn't go any higher than 12 milligrams. Then the patient would come back the next day and we would go from maybe 12 to 16. Certainly by day three, we would try to get to 16 milligrams and then wait at least 5 days up to 7 days to go up until we got to a maximum dose of 24 milligrams. And that was considered outlier, because the prevailing wisdom was that most patients did fine at a dose of 12 to 16 milligrams, which newer studies have bore out is really not the case, at least not now, right? So that's how we did it. So again, the rationale was the medicine was new, at least in the United States, and we wanted to be cautious. And it was really the way we did it was based on our experience with methadone. So caution was warranted, so we did it slowly. But again, same challenges as the methadone, slow methadone starts. And we saw, I can't tell you how often we saw this, even here at UNMH ASAP, where patients just never started treatment because they wouldn't be able to go into withdrawals long enough and then come into the clinic. So many patients were lost to treatment. They just never started in treatment. And of course, when people don't start treatment, people overdose and people die, right? We know that both methadone and buprenorphine reduce the mortality rate related to overdoses and also all-cause mortality by about 3.5-fold, according to some studies. So these are life-saving medications. So the risk here being that patients never stop. Right? But then came illicit fentanyl. We started seeing it around 2015, 2016 here in New Mexico. We started seeing it around 2017. And then it just, as we all know, took over, became an epidemic. I just included this. This is sort of a de-identified, but this was something we had done through the New Mexico Emergency Department Bridge Project, which many of us have been involved with here at UNM, including Brandon Warwick in emergency medicine, Sergio Huerta in internal medicine, myself, Margaret Greenwood Erickson in emergency medicine, Julie Salvador, of course, here in psychiatry. She's kind of the leader of all of us. And we had sort of, with patient consent, patients who had overdosed, this is in 2021, on quote unquote blues. We had, with going through IRB and everything, of course, we had sent these blues to a research lab to see what's actually in it. This blue was marketed as a Percocet 30. So it looked like a Percocet tablet. And this is all we had found in it, right? So you can see there's quite a bit of fentanyl, but then also a few different fentanyl analogs in there, and a little bit of acetaminophen for good measure thrown in there, and trace amounts of cocaine, probably from just manufacturing. And presumably, this changes from batch to batch, adding further uncertainty. So I think that's been the other challenge with fentanyl. So fentanyl came and everything started to change, right? And that really started leading to some major changes in how we provide treatment. But even before fentanyl came, some evolution in buprenorphine treatment had already started to happen. So in the next few slides, I want to trace what was happening even before the fentanyl epidemic, right? So let's go over this a little bit. So remember, when buprenorphine started, really slow, really gradual, patient comes in withdrawals, we started 2 or 4 milligrams and gradually build up, usually to no more than 16 milligrams. So this was the early evolution. I think many of us sort of didn't like the word induction. We used to call it buprenorphine induction. I still hear people say this. It's fine. I just think it makes it seem more complicated maybe than it is. Like we don't induct people on, on Tylenol, and we don't induct people on olanzapine, right? So I think there was this movement away from the phrase induction to just initiation, right? Why make it sound more complex than it is? Maybe that becomes a deterrent to people actually doing it. Home initiations. Our primary care colleagues like Dr. Jacobson and others kind of led the way, right? Paved the way. While primary care doctors started doing home initiations of buprenorphine as early as 2008, 2009, started tracking data. Some of the earliest data was tracked at Columbia University in New York, and found that home initiations of buprenorphine were safe and feasible, and patients liked them more. So we kind of moved from these very stringent office initiations to home initiations. These aren't things I'll go into here because it's a little bit older. And we started being more aggressive, right? So instead of like the target dose of, sort of 12 milligrams on day one, we started going up to 16 or even 24 milligrams. It should say 16 to 24. I apologize. When I was making the slide, I forgot to add a 4, right? So 16 to 24 milligrams. And what I haven't included here, because it's really not initiation technically, which I want to focus on, is that newer data is showing, some studies that came out in the last 2 years, is that when people are actually stabilized on 24 milligrams, they tend to do better than patients who are stabilized at 16 milligrams or less, right? So we're finding that this old wisdom of no more than 16 milligrams is also outdated. And in fact, we're in the process here of wrapping up a clinical trial. It was a multi-site 5-year trial that I actually am seeing a participant for right after this. And many of us, Dr. Jacobson has been involved in it before, Dr. Huerta, Dr. Warwick, Dr. Pandey before as well. And now we're starting to see data. We've had over 1,000 randomized participants across the country, across about 20 sites. And what we're finding is that dose of 32 milligrams of buprenorphine is outperforming people on 16 milligrams, right? And it is FDA approved up to 32 milligrams. So so that's the other evolution that's happening. Then came this trial in 2015 by Gail D'Onofrio out of Yale. And recently, not too long ago, some psychiatry residents were asking me, like, for high impact or what I thought were some of the most impactful publications in the field of addiction psychiatry in the 21st century. And one of our addiction medicine fellows was compiling a list of these. And to me, this trial, which I've listed in references, is by far, at least in my humble opinion, the most impactful addiction psychiatry trial in the 21st century. I would rank this number one without hesitation. Because until this trial came out, the wisdom was that opioid withdrawals are not emergencies. So they don't require emergency treatment. So if I went to the emergency department in opioid withdrawals or opioid addiction, opioid use disorder, I would be given a list of references. Go seek care. Weeks would pass, months would pass, right? And then what Gail D'Onofrio did was pretty brilliant. When people came into her ED with opioid-related reasons, like opioid withdrawals or whatever, abscesses, they got randomized to 3 groups. One group basically just got, referral, treatment as usual, which was kind of the referrals, here's where you call. The second group got referrals, plus they got a motivational interviewing-driven brief intervention, right? Cool, maybe that would help. And the third group, she just started them on buprenorphine right in the emergency department, right? And what she found, right, is that this was the primary outcome. So people who got started on buprenorphine right in the emergency department, 78% of them were engaged in addiction treatment 1 month after that randomization. Compare that to the group that was just got the referral, only 37% of them were engaged in treatment at 1 month. And people who were assigned to that, who got that brief intervention, only 45% or less than half. But people who actually got started on buprenorphine, look at that. That number was, very high, right? 78%. So dramatic and significant difference, P of less than 0.001. And the people who got started on buprenorphine right in the emergency department also significantly reduced the number of days of illicit opioid use per week, from 5.4 days down to 0.9 days, right? Because treatment helps. So they got engaged in treatment and that helped them. So pretty dramatic. And I will say, and again, staying with that consistency of point that Dr. Waldorf exemplifies, in 2025, I would say emergency department initiated buprenorphine is the standard of care. It is not optional. There are lawsuits happening, believe it or not, for patients who don't get started on buprenorphine, they present acute care setting. This is the norm. This is the standard of care. And I think this is why we should care. So that's the early evolution. I'm going to glance at the time. We're doing well. I'm going to leave time for questions. Hopefully, I'm tracing this evolution, which is what I wanted to do. So now comes fentanyl, right? So that brought these clinical challenges. So before I get to that, we have some data on how well our treatment works. And I included this slide because there is often this prevailing narrative I hear that our medications for opioid use disorders don't work or don't work too well in patients using illicit fentanyl or high potency synthetic opioids. I think it's challenging, but they do work, right? So this is a study, Sarah Wakeman has done quite a bit of work on this, but showing that even in patients primarily using fentanyl, methadone did reduce mortality and improved abstinence rates, but the relapse rates were higher. With buprenorphine, it's been shown actually treatment retention is about the same, whether someone's using heroin or whether someone's using fentanyl. But opioid abstinence rates are slightly lower at 6 months, right? And people say the doses, again, the higher doses for both methadone and buprenorphine, we are seeing. Naltrexone, injectable naltrexone, which I'm not focusing on here because we still don't have a great way to start it, right? So I'm not really focusing on that here. But illicit fentanyls have made the process of induction even more difficult, right? But we don't really have great data on it yet, so I've not included this. Naloxone also works, but people may need repeated or higher doses. So here in this slide, what I would really stress is that if you reverse someone using naloxone, be sure to call 911. So, more life-saving treatments can be administered. And ideally, that can be the bridge to them getting started in treatment, right? Certainly in the emergency department, or increasingly, we're looking at moving things upstream around the country, including here in New Mexico. We're looking at ways for our first responders, right? EMTs, paramedics to be able to initiate buprenorphine right in the ambulance. So that's another thing, although I'm not focusing on it, it's happening. Buprenorphine, in clinical trials, most people are doing fine with these inductions, right? And see, that old habit. I use inductions here and not in a sarcastic way. I think that was just me falling into my old set patterns. Most people are doing fine with initiations. But anecdotally, we're seeing more and more reports of precipitated withdrawals in people using illicit fentanyl when they're started on buprenorphine, right? So why is that happening? And it's been sort of a puzzle, and there is no one answer. Some people have theorized that, with prolonged use of illicit fentanyls or fentanyl analogs, there is reduced renal clearance. So it kind of builds up in the system. It's also lipophilic. So is it that it's stored in tissue and gradually released? So it's kind of prolonging how long it takes for people to be in sufficient withdrawals. Interestingly, precipitated withdrawals are not seen. If someone's on the fentanyl patch, you take it off and put on a butrans patch, the transdermal buprenorphine patch, we don't see precipitated withdrawals. So something's different with illicit fentanyl, right? And I think, again, there are many reasons. I won't go into this slide in too much, but I think it has to do with, when people are using illicit fentanyls, they're often using much higher doses for much longer time, right? Also, there's a lot of unpredictability in what they're using. So I think that also takes time. And I think those probably have to do with it. I think this is ultimately my thoughts. I think two things are happening why we're seeing precipitated withdrawals. So precipitated withdrawals, for those who may not be familiar, are what happens, withdrawals that can happen after the first dose of buprenorphine, right? Because buprenorphine has a stronger binding affinity for the mu opioid receptor. So say I'm taking heroin, it's a full mu agonist, it's saturated all my opioid receptors in my brain, and I take some buprenorphine. Buprenorphine has a stronger binding affinity for those mu opioid receptors. So what it's going to do is pretty quickly kick out all those other opioids. All that heroin that was attached to my opioid receptors is kicked out. And so I feel withdrawals, right? While buprenorphine slowly saturates and takes its place, I feel those withdrawals. That's what I mean by precipitated withdrawals, right? So I think two things are happening. One is that buprenorphine is started too soon. So people have these precipitated withdrawals, right? Because, again, maybe because with illicit fentanyls, it's sticking around in the system for such a long time that people are not quite withdrawing when we start buprenorphine. So they go into withdrawals. I think the second scenario, which I've actually seen a lot, and in my sort of not empirically informed opinion is maybe even more common, is that we're not starting buprenorphine soon enough or aggressively enough, right? I've seen this multiple times at ASAP where patients comes in, they were seen by an outpatient provider who were told, you gotta wait 48 hours until you're in severe withdrawals, and then here start with 4 milligrams of buprenorphine. So by the time they start buprenorphine, they're already in withdrawals, and that tiny bit of buprenorphine just doesn't do enough. So it's not true precipitated withdrawals, but it's expected withdrawals that are not treated adequately. So I think that's something else that we're seeing a whole lot. So step one is always assessment. When was the last use? What are you using? What's the current level of withdrawals, right? And that's the most important part, assessing it with a validated scale, such as the COWS, Clinical Opiate Withdrawal Scale. And I always ask, are there other substances present? Because that can influence the COWS. So for example, if I'm withdrawing from opioids a little bit, but I just smoked a whole lot of methamphetamine, guess what? That's going to push my COWS up because my pulse is going to be elevated. I'm going to be anxious. My pupils are going to be dilated, right? And that's going to artificially push up that COWS. So you run the risk of giving buprenorphine too soon. So don't forget to assess for that. So now let's get into all the different approaches. Evolving, really, we've seen in the last several years become very popular. So first approach, which many people have heard of, I think this is the most widely known approach. This is the one I get the most questions on, is the microdose approach, right? So what is the microdose approach and what's its history? Let's talk about that a little bit. I'll start with a little case vignette with identifying details change. 61-year-old male, long history of opioid use disorder, interested in buprenorphine treatment, no other substance use disorders. That's what this SUD stands for. But they're very afraid of precipitated withdrawals. I can't go into withdrawals. I don't want to go into withdrawals because of buprenorphine, and I don't want to wait 12 hours or 24 hours to feel those withdrawals because I know I won't tolerate it. And the minute I feel withdrawals, I'll just use other opioids. So we use something called modified Bernese method to get them started on buprenorphine, to switch them over from their full mu agonist illicit opioids onto our partial agonist buprenorphine. So the basic idea is this. You continue, and this is a big departure from the traditional way, right? If you remember, in the traditional way, we told patients, stop using all opioids for at least 12 hours, 16 hours, even 24 to 36 hours if you've been using a long-acting opioid. And that's what people are afraid of. So here we say, you know what? Keep using what you're using. Keep smoking those fentanyl tablets. We do harm reduction, of course, right? We give them fentanyl test strips. We give them naloxone. We talk about, we provide overdose education. But we say it's okay for you to continue using your full agonist. And then we introduce tiny, tiny amounts of buprenorphine, right? The idea, and over about a week, 4 days, 7 days, we gradually build up the dose of buprenorphine until it reaches about 12 milligrams or 16 milligrams. So what's happening is that although the patient is using that opioid, as we increase the dose of buprenorphine, each day, the buprenorphine displaces a little bit more of the other opioid because buprenorphine has that higher mu-opioid binding affinity. So although the patient continues using the opioid, after about a week, the buprenorphine is largely what has saturated their mu-opioid receptor affinity. So it's a way to cross-titrate, right? But the medicine, through its pharmacologic property, is really doing the cross-titration for you. And after about 7 days, once people reach about 12 milligrams, then we ask the patient to jump off of their full mu agonist. We say, okay, at this point, stop using the fentanyl. We give them some comfort medications and aggressively titrate up the buprenorphine until they feel comfortable. There are many different ways to do it. Some of the early methods, there was the Zurich's method, which came out of Zurich, right? Which was used with the transdermal patch, right? And the Bernese method, which became more popular largely because of access, is starting with tiny amounts of sublingual buprenorphine. And then there are hybrid methods like the Kornfeld method that was designed by Harvey Kornfeld out of UCSF, who combines the two. There are all kinds of ways to do it. I won't go into the nitty-gritties of it, but I'm happy to talk to anyone offline about these nitty-gritties, but there are many ways to do it. There is no one magic way. But believe it or not, some of the earliest applications of the microdosing approach that I remember were back in the mid-2010s in people with chronic pain. who were having a hard time with, who were having side effects or had developed a tolerance or a substance use disorder to a sustained release opioid, and they would have the hardest time coming off of it. We were using, and I remember doing quite a few consults using the hybrid method to help them transition over to buprenorphine. So that's when we first used it, although it's popular now in the treatment of opioid use disorder. And how low our doses are we taking? Look at how low it is. On day one, we start with just 0.5 mg daily, tiny dose. One of the residents, psychiatry residents, several years ago, kind of told me that in the age of fentanyl, we don't just talk conversationally, we either whisper or we shout. And I love that analogy. This is the whisper method, right? We're whispering to the patient, very gradually building them up. So it works. No magic, you can extend from 7 days to 9 days if needed. 5 days, there is no one way. Don't forget to use comfort medications aggressively. Patients do need it, especially when they jump off of the full agonist. Do frequent fall calls or check-ins. At ASAP, we encourage them to come back so we can see them, establish that strong therapeutic alliance, things that we as behavioral health professionals do, right? Importance, education. I think nursing is key. Many places they have used peer support specialists, can be critical in this alliance and helping support the patient through this process. There are models of it out there, where peer support specialists sort of pair up with a patient and help support them as they make this transition. Pharmacists have played this role. Certainly nurses play this role. So really, truly interdisciplinary. But the big challenge is retention and how often can people actually make this transition. And this is a patient at ASAP. I changed all identifying details. This is a patient who was a 36-year-old female, history of severe opioid use disorder, had been taking 7 to 8 blues daily for the past many years, had a history of severe trauma, PTSD, complex PTSD, worked in a professional capacity. Methadone was not an option. She was afraid of precipitated withdrawals, really wanted to do this microdose approach. And we tried this for several weeks. We tried it again and again, and we kept bringing her back, but she was never able to make the transition and was eventually lost to care. And in my experience, this is not uncommon. And in fact, the recent study that just came out in 2025, I tried to include a lot of new studies here, of course, showed this. Not a huge study, 126 adults over 175 attempts, but what they found is that only about a third of patients successfully initiated buprenorphine using low-dose initiation strategies, right? So only about a third, about 2/3 were lost to care. So we can do better than this. So I think this works for some patients, but we should have other approaches in mind, right? There are other possible solutions. People are doing ultra rapid microinductions. I won't go into that too much. Use of transdermal patches. So things are being tried, but we don't have great data on them yet. So that brings us to the shout approach, to use the very eloquent analogy that our psych resident used. We'll use the macrodose approach, right? And I think this works well if patients are already in withdrawal. Sometimes they come in and they're already withdrawing and we can jump right to it, right? And I love this. Bias is that I'm a big fan of the macrodose approach. But the caveat is that it's not about what I'm a fan of, right? It's gotta be a collaborative decision. It's gotta take into account much more than what I think, what the patient thinks and what's going to be acceptable to the patient, because without that, it's not gonna work. So again, I'll use a vignette. These are all patients at ASAP with identifying details changed. A 46-year-old female with a long history of severe opioid use disorder, taking 40 to 50, smoking 40 to 50 tablets containing fentanyl every day, occasionally injecting them, history of multiple unintentional overdoses. She went to a detoxification unit, but left before ever receiving her first dose of buprenorphine because she said, quote, I was just kicking too hard and they weren't doing anything, right? My guess is, and my understanding is that they were using the traditional approach. They were waiting for her to go into withdrawals and it was just too intolerable for her, so she left. She had failed microdose and traditional initiations, was not a candidate for methadone due to baseline prolonged QTC interval, had a history of hypertension, non-insulin dependent diabetes and PTSD, and was already at a COWS of 15, right? So we had a discussion about aggressively starting her on buprenorphine, and we use a macrodose approach. Remember, historically, the big fear was, are we going to throw people into respiratory depression? But we actually have lots of studies, even in people who are not tolerant on opioids, that buprenorphine actually has a pretty significant ceiling in respiratory suppression. So this is just one of the many studies where you can see, right, the buprenorphine dose, and this is IV. People's respiration sort of ventilation comes down, but it evens out at a pretty safe range. There are other studies showing the same thing with O2 sats, with respiratory rate. So buprenorphine in healthy adults is actually quite safe. By comparison, this is fentanyl. And you can see just this, ventilatory failure, right, essentially happening with increasing doses. We don't see that with buprenorphine, right? This is effects of high-dose IV buprenorphine on experienced opioid abusers. I don't like this term, but that was the term used in this study. It's an older study. And you see a similar thing where you essentially get a plateauing of respiratory suppression. So it's pretty safe to use. So the process is, and we do this all the time now. In fact, we did this at ASAP. I believe Justin was on. Didn't you do this, Justin, just a couple of weeks ago on a patient? Where we gave the patient 16 milligrams of buprenorphine. We administer buprenorphine 16 milligrams if they're already insufficient withdrawals. And then we can redose every 30 minutes to 1 hour until we get to 24 or even 32 milligrams, right? So you can see how dramatically different this is from those 2 or 4 milligrams every couple of hours until you get to 12 and 16 by day 3, to now we're saying we even start with 16 and get up to 32 on day 1 if we need to. That's macrodose. And then to add to it, people started looking at, can we then follow it up with a long-acting injectable buprenorphine formulation? So that became kind of a hot process, right? And there's good reason. This is the evolution, right? We go from macrodose, microdose, then macrodose using sublingual to macrodose using sublingual, followed by rapid initiation onto the injectable long-acting buprenorphine, because that does something really important. It gets the blockade going, right? It buys time for those systems of care. So if you see someone in the ER and you get them on a long-acting injectable buprenorphine, it's buying the patient some time, 7 days, 28 days, depending upon the formulation, to get them engaged in care. So you're less worried about losing them to follow-up. And because the buprenorphine is providing that blockade, right? If people use other opioids, they're kind of protected from overdose. So that's the importance. So that kind of became the next stage in evolution. And that was different because for Sublocade, which is I'm using a brand name for disclosure. I don't have any financial conflicts. But I'm using the brand name because the product states that patients have to be stabilized on a stable dose of sublingual buprenorphine for at least a week before starting them on injectable buprenorphine. What people started doing is saying, you know what, we're just going to do it. We're just not going to wait 7 days. Once we know that patients have tolerated sublingual, we're going to get them onto the injectable buprenorphine, right? And it does something else. I think this is the big piece, this very gradual tail over several days, right? So initial studies were out of, by John Mariani's group out of New York Presbyterian Columbia University. The first thing he did was patients came in with opioid withdrawals. He started them on buprenorphine, right? Sublingual, built them up to, a therapeutic dose until they felt better, and started them on the injectable. This was a case series by day 2 or day 3. So instead of that 7 days, he reduced that time on sublingual to 1 to 2 days, right? And then got them on buprenorphine and said, you know what? Patients did really well. Can we actually push it? So then he did a second case series where instead of those 2 to 3 days, he moved it down to 1 day. So just on the first day, patients got buprenorphine until they felt better. And before they left, they got an injection that lasts for a month. So now we went from 7 days to injectable to just 1 day to injectable. A big difference, right? And that's what we did really for the patient whose vignette I presented. Thankfully, we actually had, because she was Medicaid and she had previously tried it, we actually had an injection of long-acting buprenorphine under her name at ASAP, right? So she basically built up to 24 milligrams of Suboxone at home, came into the clinic the next morning, and we gave her an injectable buprenorphine formulation, and she did really well. And she got on that, she stayed on it. Then people pushed it even more. right? And that's what I want to go into in the next 10 minutes or so. So we went from microdose and macrodose to macrodose using sublingual, followed by a rapid transition to injectable buprenorphine, to people saying, what if we just did away with that sublingual altogether? What if we just really pushed the boundaries and started people right off the bat on injectable buprenorphine? Pretty revolutionary, in my opinion, right? But rationally, it makes a lot of sense, right? And I'm going to go back to this because essentially what we're doing when we start people using injectable right away is we're combining the microdose and the macrodose, right? What do I mean by that? I'm going to go. So this is sublingual buprenorphine, right? And I'm going to see if I can do a little pointer, a fancy pointer. Maybe I can. So this is sublingual buprenorphine, hours. So you can see how rapidly the levels go up, right? By about, you're seeing them rise if we, by even about 4 hours post, even in a couple of hours, right? Like it's peaking and then gradually tapering off. So if someone's not quite ready, they still have other opioids in their system, this rapid rise can throw them into withdrawals, right? And then it leaves. By that point, the patient's miserable, they've left your care, they go out and they're withdrawing even worse because this threw them into withdrawals, so they wind up using. That's not what we want. So compare that to what, this is the weekly preparation of injectable buprenorphine, and you can see that the levels gradually rise, and this is the first injection to peak after about 1 day. So what are you doing over this day? You're basically using a rapid microdose approach because the levels of buprenorphine are going up rapidly, or slowly rather, over about 24 hours. And as they do, they're displacing that fentanyl or that heroin. So instead of doing that in 1 to 2 hours, it's doing it in about 24 hours. That's like a rapid microdose approach. But then you got the long tail, which gives you time to get them engaged in treatment. You give them the second injection, and now the levels start going up even more in subsequent injections. So you get a really good blockade going. So that's kind of the idea. So it makes a lot of sense. And I've been, I feel very fortunate that over the past several years, I've been pretty involved in the design and review of some of these trials. And we at UNM in the emergency department with Cam Crandall, Brandon Warwick, have played a role in some of these trials as well. So, so I think just a shout out to all our UNM colleagues and in playing a role in this as well, right? So we come to this, what's called direct to inject buprenorphine. So this was an interesting study. This is one that I had a role in designing it and reviewing it and all that, which was really exciting. This came out, was able to be published a couple of years ago, where what happened is, and this was also done by Gail D'Onofrio and Drew Herring, who's at Highland Hospital in Oakland, California, another pioneer, in this field, and Kate Hawk, just a lot of really cool, innovative people. So patients came into the emergency department, and if they were withdrawing right away, right, the idea was give them injectable 7-day buprenorphine, right? The other revolutionary thing they did is that they started patients even with minimal opioid withdrawals. So historically, we say your opioid withdrawal should be at, COW score should be at least 8 or 9, maybe even up to 13 before starting buprenorphine. But here, they were started even if they were not in withdrawals, 0 to 7. So pretty groundbreaking, right? And basically what they found is that people tolerated this injection of right away of 7-day buprenorphine if their COWs were 4 or greater, right? So they didn't do so well if their COWs were 0, 1, 2, or 3. But even at COWs of 4 to 7, which historically, even 3 years ago, I would never have dreamed of doing, people were tolerating. And I think it's because of that gradual upslope of concentrations that people are tolerating. Direct to injection allows to more aggressively start that. This was a study, I don't know why I put this parentheses, I apologize, shouldn't be there, in an outpatient setting. This was done in the ER setting, this was done in the outpatient settings, and they based this study on the D'Onofrio trial. So they said, if your COWS is under 4, we won't intervene. But if your COWS is 4 or greater, we will get you started with this weekly formulation of buprenorphine, right? And most people were using illicit fentanyl, 80%. And again, what they found is that, about 37% had no withdrawal, another 31% had mild to moderate withdrawals, only 11% had severe withdrawals, right? And 21% were missing data. But look at this, 72% continued buprenorphine beyond the initial injection, and most transitioned to monthly formulations. Much better than the 34% we saw with microdose, right? Here we're seeing 72% getting started in treatment. And retention rates were pretty good, 69% at 7 days, and even 68% at 30 days, dropping to 43% at 90 days, right? Another trial published in JAMA also in 2025. I've tried to use, this is also 2025. This is 2024. So I've tried to use very recent studies. This is all new. Similar idea. Patients came in, rapid initiation onto long-acting injectable. I believe here they did a 4 milligram buprenorphine test dose. Then they gave them the 300 milligram monthly injection. And you can see that, retention is higher compared to the standard initiation, right? 66% to 54% at 30 days. And this was a multi-site trial. So this is feasible, this can be done. And this is, I won't go into it in too much detail, but you do want to counsel patients. We want to have that rapport with patients. We want to talk to them saying withdrawals can happen, right? Because again, the injection is going to take 24 hours to really become effective. And in that time, the opioid withdrawals can worsen because that's the natural history of opioids, right? As hours pass, you go into withdrawals. So we encourage them, we provide motivational interviewing, we engage them, and see, explore the reasons why they may not want to take other opioids, right? And that's really the big part of the counseling. And generally, you want to follow up pretty quickly in 24 to 48 days and get them started in treatment. This is another really interesting trial out of Washington, also in 2025, where they kind of pushed it even more. So now if a patient went into their clinic, right, into their center, on day 1, they got the 8 milligram weekly injection. Then on day 2, they got the 16 milligram weekly injection. On day 3, they got a monthly injection. So they basically aggressively build up the doses so that by day 3, they're on a monthly injection. So another aggressive thing to do. Small study, but you can see that 75% actually completed the protocol. So 75% of them were able to get onto the monthly buprenorphine injection, and 64%, I think this is the important stat, actually came in to receive a second monthly long-acting injection. So pretty cool. Again, counseling is very important, really giving, sort of establishing rapport, providing support, talking about withdrawals that can happen, making sure they have comfort medications available to them. Oftentimes, we'll also give sublingual buprenorphine to take on top of it, right? Yeah, you're on this, but if you need it, here, take this other buprenorphine 24 hours after the injection if needed. And harm reduction, naloxone, fentanyl test strips, all good practices, right? Something Dr. Kavanaugh is really championed here at ASAP. Some of the other innovations, last thing I'll talk about, right? This is all by Puya Azar, who's at Vancouver. He's kind of my hero. He's really pushing the envelope and doing all kinds of cool stuff. So he did this, it's a case report where basically someone came in, the patient really was like, can you just like get me? No one's been able to get me on buprenorphine. Can you just help me get on buprenorphine? So they talked about it, the patient consented. So he basically used tiny amounts of naloxone IV to precipitate withdrawal. A big caveat here, don't read this and next time you see someone, give them a Narcan spray. That Narcan spray has a lot more naloxone than 0.1 milligram of IV naloxone, right? So patients will be miserable and wind up in the ICU. So please don't do that. This was done using an IV 0.1 milligram naloxone. So they gave it basically every couple of minutes in increasing doses. And when the cow score hit 13, they gave them 8 milligrams of sublingual buprenorphine, right? Tracked them, their cows came down, and they gave them extended release. So here, using IV naloxone, he tapered off, and this patient had tried and failed buprenorphine. I talked to Puya about this for like months. They had tried multiple times, had never been able to get onto buprenorphine. Were using multiple opioids, high doses. And basically within 2 hours, the patient was started on 300 milligrams of monthly extended release injection, right? They're also doing other things, but this was kind of one I wanted to highlight. So what about methadone? Have things changed with methadone? That's the last thing I'll leave you with. Methadone is a little bit tricky in the United States because of federal regulations. One change did happen. In the last few months, the federal law changed. So now the first dose we give went from 30 up to 50. So now we can start people at 50 milligrams of methadone. Awesome, right? Also, another study has come out, which I did not cite here, but if someone wants the reference, I'm happy to provide it, showing that patients who are built up to at least 70 milligrams of methadone by the end of week 1 tend to have a significantly higher treatment retention at 30 days. So remember, in the old days, by the time 1 week hit, we were getting to maybe 50 milligrams or so, right? But now we're saying we want to get people to at least 70. So Puya again pushed the boundary. This is another Puya Azar special, saying, but our patients have such a high tolerance when they come in if they're using illicit fentanyl. Can they actually tolerate a lot higher dose of methadone? So what they did, and this was actually a fairly elegant study, they're tracking blood levels and PKs and all kinds of stuff. But essentially, when patients came in, he used IV fentanyl, rapid intravenous IV fentanyl, right? Basically to, dosing it repeatedly until patients' withdrawals were, controlled and they were not sedated. And then they used that dose of IV fentanyl to calculate the equivalent dose of methadone. And the first dose of methadone patients got was that bioequivalent dose that they calculated. And in his early, study, patients have received up to 200 milligrams of methadone as their initial dose. We can't do that legally or ethically here in the United States, but I highlight that to show that we are probably cutting too much on the cautious side, right? These are patients with tolerance who really were able to tolerate up to 200 milligrams. And he hasn't published this yet, but he's got a longer case series and more data gathered where people are easily tolerating 120, 150 milligrams of methadone as their initial methadone dose. What will happen with this? I don't know. Maybe this will eventually lead to federal law changes, but it is exciting. This is just how the conversion that he used. I think there's some big barriers, insurance coverage, them approving it up to 32 milligrams. I think the big thing for me is that we need to be stocking injectable buprenorphine in all formulations across our clinical sites. I know ASAP has it. Many of our primary care clinics have it. North Valley Clinic has it. Some of our other primary care clinics have it as well. And I think, and I'm comfortable saying this, we need to have this in all psychiatry settings. We need to explore ways to make that happen, including in PES, PUC. So I think that's where I'll leave it. I think traditional ways of starting medications for opioid use disorder, that's this MOUD, are rapidly becoming less useful in the era of high potency synthetic opioids. A variety of novel approaches provide possible solutions to get people rapidly started on life-saving treatment. I think it's exciting, it's useful. I can't wait to see where the field goes. And I hope this tracked the history. This was somewhat important, maybe gave you some new information and useful. I will stop here and turn it over to questions. Thank you.
Thank you so much, Dr. Bhatt. Really just such important information. Folks, we have a few minutes for questions, so I would say either put it in the chat or just unmute. That would be great. Dr. McQuarrie.
Hi, I really loved the presentation. So I had two questions. I came with a question, so I want to ask that. But based on the presentation, I was just curious. So when you do the drug to injection, what do you advise patients in terms of their ongoing usage?
Yeah. So what I tell them, what we tell them is that I do tell them this is off-label, right? Because it is off-label. With the Sublocade formulation, the label states that you have to be on a stable dose of buprenorphine for 7 days. And the Brixadi formulation isn't so stringent, but it does still require at least one test dose. So it's off-label with both. So we have that discussion. about them, right? So that's important. Second thing we tell them, and that's where those expectations are important. We educate them that, again, this is going to go up slowly over 24 hours. So some degree of withdrawals are expected. So we really encourage them to avoid using other opioids. We give them comfort medications and say, take this if you need to. Again, if we can, we also give them buprenorphine sublingual with the education that don't use them for the first 24 hours after the injection, right? And we tell them that if you must use opioids, that's where the harm reduction comes in, providing them naloxone, and then frequent follow-ups. And I think this is where the coolest thing I had seen was actually at a IHS site, where they were pairing up patients who were doing some of these things with a peer support specialist. And I just thought that was just awesome, right? And they had like a clear person with lived experience who could support them through that. So I think those are also worth exploring beyond just medications. Does that answer your question?
It does perfectly. Yeah, yeah. I was just thinking, because with the microdosing, you were saying that you continue to use. So I was just curious how it intersected with this, which has a microdosing component to it.
Yeah.
The other question, if I could ask, I was just curious your thoughts. If someone's a polysubstance abuser and they're using alcohol, and you want to give naltrexone for that purpose, but there might be opioids in the picture, would you advise naltrexone, or you would not because they might overdose or what have you?
Well, so you wouldn't, right? Because you wouldn't be able to take naltrexone and buprenorphine together. It would have to be.
Yeah, no buprenorphine at all in the picture. Just this is a polysubstance abuser, alcohol, occasional opioids in the mix.
I think that's reasonable to go naltrexone route, right? But I think what I might do is in that patient, I might prioritize injectable long-acting naltrexone. Because while both oral and injectable work well for alcohol, oral doesn't really work well for opioid use disorder. Whereas injectable long-acting naltrexone, once initiated, is about as effective as buprenorphine, right? So there may be rationale for some patients in using injectable naltrexone for both. But caveat that for most patients, there are some studies looking at it, that if someone has both alcohol and opioid use disorder, outcomes tend to be better if patients are on buprenorphine plus acamprosate than just injectable.
Oh, wow. Oh, that's good to know.
So,
okay.
Limited evidence, but there is some suggestion in literature of that. So, yeah.
Dr. Towen, I see you have a question. And Dr. Bhatt, there are some questions in the chat that I don't know that you'll get a chance to get to before we run out of time. Emily, is there a way that you can make sure that Dr. Bhatt gets those questions?
I can quickly address those.
Okay.
And it's okay to go. It's okay to go over too if you need to.
Okay, and Dr. Towen was first.
Thank you, Dr. Waldorf. Dr. Bhatt, I am proud to be in the same department than you. Great presentation. So in terms of PS, what protocol do you think we should start or go in stages, and when? And second, what study do you propose we can do at PS? Doesn't have to be a double-blind control, could be observation. Your thoughts, Dr. Bhatt?
Great question. So I think I actually, when I presented maybe a few months ago to our PGY1 and 2 psych residents, maybe some of you were in it, where I'd actually sort of created an acute care algorithm that can be used at PES. And I'm happy to send that out. It's a different PowerPoint, but I just sort of created it for the PGY1 and 2 psych residents, sometime in the fall, I want to say. So I can send that out. And yeah, I think starting with a small case series, right, would be the reasonable thing to do at PES, where, we can do it. I do think, right, I think starting by exploring getting involved with the REMS program, so we are stocking long-acting buprenorphine, I think that's the starting point, because that opens the door to all of these other things, right? And then when patients come in, and this also ties into some of the questions here in chat, actually, right, Dr. Waldorf? Where we could, if we have that, actually use some of this direct to injection or macrodose sublingual followed by injectable before discharge. And now, especially with CCBHC, patients can walk into ASAP, right? Like the very next day, avoiding this understandable hesitation that we have. that I'm starting them on this medication, but what's the follow-up? So if that's helpful, I can send that out later, just the PowerPoint to all the residents or whoever's interested.
Dr. Waldorf, can I make a follow-up comment?
Of course.
So maybe, Dr. Bhatt, what we should consider is having a protocol that all of us PS providers and residents participate, make that be a condition to continue to have the privilege of taking care of patients here.
I think that would be great. And the ED Bridge project, and I think Julie, I think Julie's on, yeah, or she was on. I saw her earlier. Hi,
I'm
Julie.
on.
Yeah, I think the ED Bridge project would probably be a great team to consult with to help create some of these PES specific protocols. And I can certainly, of course, help with that.
Yeah, and I think there was a training there recently with the residents, at least with John Kavanaugh and maybe Surgeon Huerta. Okay.
That's right. So I think we can keep building on that momentum. That was sort of my hope with this grant rounds today anyway, so.
I definitely think that Dr. Rose's question with regard to macrodose initiation, you were talking about a little more in general. Dr. Richards has a question specifically about.
Right. Yep. Great question, Dr. Richards. So in our trial, the RDD trial, which was a NIDA-sponsored 5-year trial, we had a small group of patients who the highest dose did not hold them. I think there are a few things to consider. One is you could try to do injection every 3 weeks instead of every 4 weeks. I think that works, but we were able to do it because the medications were given to us by NIDA and not by an insurance. So in that case, it's usually that last week, that week 4, if it's going to happen, where patients might experience cravings or withdrawals. So combining it with additional sublingual buprenorphine, I think is a reasonable strategy. The other thing is if they're on Brixadi, and again, I'm only basing this, there's no clinical trials. I'm only basing this based on my understanding of pharmacology of the two medications. The sublocade at a steady state at 300 milligrams achieves higher levels than Brixadi at the highest dose, which is 128 monthly. So if someone's on Brixadi, not holding them, that may be another approach to try, but switching them to sublocade to see if that helps. But again, there is no sort of great clinical data to base that on. So very often we just wind up either exploring giving the injection sooner or supplementing, just as you're suggesting. Thank you.
Any other questions?
Mars throws out a shout out to California Bridge. Agree. Yeah, great resource for everyone.
Okay, and Mars, you saw Dr. Rose's request to send it out to all the residents.
Got it.
All right. Well, I think we've come to the end. Dr. Bhatt, always so informative and compelling, and thank you so much for the continued work that you do, not only for the patients, but for keeping us all trained, whether faculty or learners. So thanks everyone for coming. Hope you have a great weekend.
Bye.